So respected chairpersons and all the audience, good afternoon. So my topic of presentation is cardiometabolic risk among young adult population in Bangladesh, a nationwide survey. It is a joint research initiative of Non-Communicable Disease Control Program of Director General of Health Services of Ministry of Health and Family Welfare, Bangladesh, and Center for Global Health Research, Diabetic Association of Bangladesh. So outline of presentation includes backgrounds, objective, material methods, result, conclusion, and including with some recommendation. So we all know diabetes and other NCD, including the 2030 Agenda for Sustainable Development Goals. And the main aims to reduce premature death from the cardiovascular disease, cancer, diabetes, chronic respiratory disease by 25% by 2025. So therefore, NCD Alliance, International Diabetic Federation, World Heart Foundation, WHO call for a simultaneous action on diabetes and hypertension for more resilient health systems. So now come to the Bangladesh. According to the Bangladesh NCD Risk Factor Survey 2018, NCD contributes 60% of the total death in our country. If you see the slide in the right side, the study also reported 97% of the study participants had at least one NCD risk factor, which include current tobacco use, less than 5 servings of fruit and vegetables, less physical activity, diabetes, hypertension, and overweight. That indicates that the NCD will create huge healthcare burden in our country in coming years. National Step Survey 2018 also reported 8.3% diabetes and 21% hypertension in Bangladesh. We have found a difference in the variation in the prevalence of diabetes hypertension in different age group. In Diabetic Association, we also conducted a national survey in 2019. Sample was 100,000, and we also cover almost 90% of the whole country. Our survey reported 22.6% diabetes in Bangladesh, which is in line with the study conducted at the same time in the Pakistan and most of the country in the MENA region. But if you see the good knowledge, only 38% of the participants had the good knowledge about diabetes. You should know that 30% of the total population in Bangladesh is young adult. But still, we do not have enough data related to cardiovascular disease in this age group. Considering all this, we conducted a survey in 2021. This is last year. General objective of our study was to assess the prevalence of the cardiovascular risk marker, include diabetes, hypertension among the young adult population in Bangladesh, and its variation by the division, urban versus rural location, and individual level socio-demographic and clinical characteristics. Secondary objectives were to assess the rate of the obesity, dyslipidemia, and metabolic syndrome among the young adult population. Second was to assess the macro and microvascular complication related to diabetes, hypertension in the young adult population. Third one, to identify marker of the diabetes, hypertension following different anthropometric indices, and to develop the country-specific cutoff level for anthropometric indices, including BMI, waist circumference, waist hip ratio, waist height ratio, and neck circumference. And last one, to investigate the serum lipids, including total cholesterol, triglyceride, LDL cholesterol, HDL cholesterol, separately and in combination, and their association with diabetes and hypertension in this age group. Subject and method was a total of 2,460 young adults aged 15 to 35 years participated in this cross-sectional study, which is conducted in the 8 urban and 8 rural areas division of Bangladesh. From 28th August to 20th October 2021, we use multi-cluster sampling techniques for the selection of the study sites. And we also use the population percentage of the each division following the census of 2011 for sample distribution. We use semi-structured questionnaires and face-to-face interview for data collection. So this is our study sites. We cover almost all the part of the country, all the division. Selection criteria. Inclusion criteria includes permanent resident, both genders, age in between 15 and 35 years, being able to communicate, willing to join the study. Exclusion criteria: age less than 15 years and more than 35 years, taking medicine known to alter OGTT, unable and unable willing to give informed consent or communicate with study staff, and currently pregnant. We followed the WHO step 1, 2, 3 procedure for collecting the study variables. Study variable includes sociodemographic variables, anthropometric variables, clinical includes blood pressure, vascular status. We palpate the peripheral pulses, peripheral neuropathy. We use 10 gram monofilament and 128 Hertz tuning fork, fundus photography with artificial intelligence, and 6 leads ECG. And for the biochemical variables, fasting to after plasma glucose, HbA1c, lipids, urine albumin. We use WHO recommended point of care machine for biochemical analysis. This is the whole process, the work plans in the middles, the member of the study teams, and the part of other volunteers involved in this study. National Professor A.K. Azad Khan, President Diabetic Association of Bangladesh, was the principal investigator. Professor Akhtar Hussain, President International Diabetic Federation, and myself was the co-PAI in this study. Now I will show the socio-demographic, some of the key findings of our study, starting with the socio-demographic information. So 55.3% of our participants aged 15 to 90 years, 87.4% participants were Muslim, which is in line with the census conducted in the 2011, which is the last census conducted in the Bangladesh. Urban participant and female participant found higher in our study. If you see the slide, 41% of our study participants had secondary level of education, and 55% have college and above level of education. Majority of our participants belongs to the middle and high income group. Now come to the physical activity. More than 50% of our study participants remain sedentary. Only 12.2% were physically active. That's they work more than 60 minutes per day. We also check the family history. 41.7% participants had diabetes. 53.2% had family history of hypertension. Almost 20% coronary artery disease. 60.5% cerebral disease. We use the Asian cutoff level definition for defining obesity and central obesity. Prevalence of obesity defined by the BMI was 26.5%. If you see the slide, prevalence was 18.2% in 15 to 19 years group, which increased to 29 in 20 to 25 years, increased to 38.4% in 25 to 29 years. And we found the highest prevalence in the 30 to 35 years, which was 55.1%. Prevalence was similar in the male and female. However, the prevalence was found higher in urban population, which was 31.5%, which is in line with the previous study conducted in the different time point in Bangladesh. Now, the prevalence of diabetes was only 7.4%, which was 4.4% in the 15 to 19 years. And it was highest in the 30 to 35 years group, which was 21%. And diabetes was found higher in the female and urban participant. And almost 61% of our participants were asymptomatic. Among the symptoms, general weakness was found the most common symptom in our study, followed by the increased urination, increased thirst, increased hunger, weight loss, and 22.5% of our participants had more than 2 and above symptom. Now the hypertension prevalence was 13.5%, which was 11.8% in the 15.19%, which increased to 22% in the 30 to 35 age group. And prevalence was found higher in the male and urban participant. So 68% of our study participants remained asymptomatic. Headache was the more common symptoms, followed by the neck pain, blood vision, tiredness, and 26.7% participant more than 2 and above symptom. Now the lipid disorder. The prevalence of the lipid disorder defined by the high triglyceride and low HDL cholesterol was 15.8%. Prevalence was 9.9% in 15 to 19 years group, which was 16% in the 22 to 24 years age group, 28.7% in 25 to 29 age group, and found highest in 30 to 35 age group, which was 37.4%. Prevalence was found higher in the male and urban participant. Metabolic syndrome defined by the ATP3 definition was 23.6%. It was 15.6% in 15 to 19 age group and found highest in 57.1% in 30 to 35 years age groups. Prevalence was found higher in the male and urban participant. In male, it was 25.8%, and in urban participant, it was 25.4%. So we also check the daily dietary habits in our study participants. Almost 100% of our study participants eat rice regularly, 61.7% routine chapati, fish 31.7%, egg 32%, meat 8.4%, green vegetables 60.8%. I missed to mention the food habits. It was 23.5%, soft drink 17%, extra salt 73.5%, fast food 14.9%. Soybean was the most commonly cooking oil in our study. It was 78.3% participant use soybean regularly. In our study, about 90.3% participants had at least one NCD risk factor, which in line with the previous study conducted in 2018, we called it a step 2 survey. Prevalence of the current tobacco user was 11%. Eat less than 5 servings of vegetable and fruit was 98.3%. Less physical activity 50.3%, which I already mentioned. Obesity 26.5%, hypertension 30.5%, and diabetes 7.4%. We also check the association between anthropogenic indices with diabetes and hypertension. In our study, waist hip ratio and waist circumference have shown a significant association with diabetes, and the BMI and waist circumference have shown association with hypertension in our study. We also check the association between blood lipids with diabetes and hypertension. Both LDL cholesterol and triglyceride have shown association with diabetes and hypertension in our study. So we also check the complications. Prevalence of the retinopathy was 4%, albuminuria 2.5%, neuropathy 3.8%, tachycardia 30%, atrial fibrillation 4.9%. If you see, the prevalence of the retinopathy was 10.2% in 30 to 35 age groups, and albuminuria was 6.7% in 30 to 35 age group. In conclusion, our study revealed a high prevalence of the cardiovascular risk factor, including diabetes, hypertension in urban and rural Bangladeshi young adult population. We need more larger scale study with control population, include all the possible influence to confirm our findings. In recommendation, early detection of the cardiovascular risk factor is likely to be cost effective, as timely initiation of treatment will prevent complication, thereby reducing the cost and unnecessary suffering, both for individual patient and society. Ensure affordable access to fundamental care for people living with diabetes and hypertension. And finally, considering local contextual factors that may influence policy intervention, such as political support, resource allocation, ability of the local data for monitoring impact. Before leaving, I would like to give sincere thanks to all the organizers for giving me the opportunity to present my study data here, and thanks to all the audience for their patience hearings. Thank you.